Good morning. My name is Dr. Frank Silvestry, and I'm here on behalf of CVI Heartbites. Here, our series is talking about cardiovascular disease in the age of COVID-19, and I've been tasked with talking to you about the bioepidemiology and clinical characteristics of COVID-19. First, a word about me. I'm an associate professor of medicine, associate chief of education in the cardiovascular division at the Perelman School of Medicine, Hospital University of Pennsylvania, and I'm a part of CVI's echocardiography planning committee, as well as on the faculty for multiple CVI events, and you can follow me here if you so desire on my Twitter account. CVI Heartbites is all about presenting you with information in the era of COVID-19 in a rapid way. And due to the rapidly changing information related to COVID-19, this session is considered up to date as of its recording today on April 20th. Remember that CVI Heartbites is not an accredited educational program, and CME or CE credit is not offered. If you would like more information, please visit us at cviphiladelphia.org, or you can follow them on Twitter at CVI Philadelphia, #CVI Heartbites. First, our terminology. We need to be clear that the virus that causes COVID-19 is the SARS-CoV-2 virus, and this produces a cellular infection by binding of its viral surface spike protein to the human angiotensin converting II enzyme receptor. The viral surface spike protein is seen here on this transmission electron micrograph, giving its characteristic appearance, which looks like a crown, hence the name coronaviruses. The ACE2 receptor is expressed in type 2 alveolar cells, among others, and therefore it is a predominant portal of entry, and thus the clinical picture of COVID-19 illness is a characteristic viral pneumonia with hypoxemia, and in its most severe form, producing an ARDS, an acute respiratory distress-like picture. COVID-19 is not just a viral pneumonia or an ARDS picture, however, and truly produces a multi-system illness with significant morbidity and mortality. And it's fair to say that COVID-19, in addition to being a very dangerous infection and really wreaking havoc in our healthcare system, has also resulted in profound impact in every aspect of our lives. And it's hard to imagine how our lives will exist after the COVID-19 epidemic is past us. The virus itself has a number of structural proteins, but the most important is this S protein, or the spike protein, which is required for cellular entry. The spike protein is cleaved into subunits by the host, in this case the human protease, a transmembrane protease, which essentially activates the spike protein, allowing it to infect cells by entering a non-endosomal pathway at the plasma membrane. The virus has a number of other non-structural proteins, which are listed here, and a number of proteases that cleave these non-structural proteins, but the most important is the S protein, again, cleaved by the host protease and required for entry via binding through this ACE2. Here you can see a comparison between the initial SARS-CoV virus and SARS-CoV-2. Again, you should ignore the case numbers for SARS-CoV-2 because this illustration was prepared much earlier, but the common features between the initial SARS-CoV and SARS-CoV-2 include binding at the ACE2 receptor in humans, including requirement of this priming by the transmembrane protease, and including a moderate or high degree of neutralization by SARS convalescent serum. Now, this is the current situation. Johns Hopkins has wonderful resources for monitoring the total cases, deaths, and testing conducted in various different geographies. And here you can see the situation across the world. This is truly a global pandemic with tremendous implications. Over 2.3 million cases as of yesterday when I prepared this slide, and over 162,000 deaths as of yesterday. Again, a pandemic infection that is resulting in worldwide morbidity and mortality, as well as a disruption of all aspects of our lives. When we drill down to the United States, there are over 700,000 cases as of yesterday and almost 34,000 deaths. The death rate in the United States appears to be doubling about every week or so. And you can see here on this global map of the United States that are particular hotspots, if you will, in the Northeast corridor, centering around New York City, New York State and Boston, but also on the West Coast and in other major metropolitan areas that, as you can see here, including Chicago, Detroit, and other large cities. In the Philadelphia area, where we are physically right now, you can see that although Philadelphia has not been as affected as the New York and surrounding areas there, you can see Philadelphia certainly does have a large number of cases as well as deaths, and in many ways, Philadelphia is primed to become the next potential hotspot without continued action and intervention. Now, COVID-19 is a truly morbid and mortal illness, and this is from the week of April 6th to April 12th. You can see that COVID-19 and the number of deaths it produced during that 1 week time period was second only to heart disease. But there were about 10 times as many deaths from COVID-19 as there were from flu and pneumonia, and many, many more times than garden variety pneumonitis. So this is clearly a disease that has a high morbidity and mortality. Now, COVID-19 illness is transmitted typically through two primary mechanisms: contact with infected droplets through coughing and sneezing. And you can either be coughed or sneezed upon and get those droplets directly onto your oral and nasal membranes, or your hands can come into contact with surfaces that are contaminated by those droplets, and then by bringing your hand to your face, you can then self-contaminate yourself. The virus was initially found in bats. It's initially a zoonotic infection, and there's a large reservoir of coronaviruses that live in bats. How it made the jump from bats to humans is still controversial, but clearly this was a naturally occurring virus that lives in a large reservoir in animals. Genetic analysis has helped us understand that this is unlikely to be a man-made virus. However, and it's also helped us to understand the epidemiology of small level mutations that helped us trace the origins, for example, of a Washington state outbreak to Wuhan, China, whereas the origins of the New York state outbreak more to travelers from Italy. So the genetic information that we get from it both can confirm that where it originally came from, which is from this bat reservoir, but it also can help us understand how different patterns of transmission have occurred. Typically, these are large droplets that we need to be concerned about. However, aerosolized droplets through certain procedures like suctioning or bronchoscopy, or potentially even transesophageal echo, can produce smaller particles, which can then result in infection. I should also mention that there is fecal oral route, which has been described. The viral PCR testing has been shown to be positive in feces of people suffering from COVID-19. So fecal oral is a possible mode of infection as well. However, the primary mode is through fomite-to-face transmission, as well as respiratory droplets. One of the things that is quite sobering about COVID-19 is that it's transmitted from asymptomatic or pre-symptomatic individuals. So those who are infected with the virus may have no signs or symptoms of an infection, and they can go on and be infectious and have a sufficient titer of viral particles to be able to infect others. There's also much uncertainty about the period of time after convalescing from COVID-19, when viral particles are still detectable, and whether or not those people are indeed infectious or not. And this has profound implications for returning to work for healthcare providers, and obviously opening up our country and opening up our economy as well. Now, the other thing to consider is that the RNA and its protein components are susceptible to degradation, and this has implications for heating or common disinfecting solutions, which is why hand washing with soap and water, or other disinfecting solutions that contain bleach, for example, or high concentrations of alcohol are so effective at destroying the virus and preventing it from becoming infectious. And certainly there's the possibility that meteorologic conditions can impact transmissibility as well, which raises questions about whether this COVID-19 illness could become a seasonal illness which recurs in the fall to winter months. Another sobering fact about the SARS-CoV-2 virus is its presence has been detectable on a variety of surfaces. This was a paper published in the New England Journal of Medicine, which looked at the surface viability on things like stainless steel and plastic, and at the end, the Data indicates that it lives for a long period of time and can be demonstrated for a long period of time. I shouldn't say lives, but can be demonstrated for a long period of time on those surfaces, and even surfaces like cardboard, it can have a pretty significant half-life of over a day. Similarly, the virus can be detected in aerosols for up to 3 hours, which has implications for transmission, especially in healthcare environments. Now, one of the lessons that we learned from Singapore is when you look in the rooms and in the wards of patients who are being cared for with COVID-19, you can certainly find PCR evidence of the virus throughout the rooms. And this has been shown both within the patient care rooms, but also in common areas where healthcare workers congregate, such as in ICUs, on the floors, on the computers, on the laptops, on the mice, the computer mice that we use, the hand sanitizing dispensers. Virtually everything has evidence for viral particles detectable. Now, each of these numbers in this particular study represents the PCR cycles that are required to amplify the virus sufficiently to be able to detect it. And a PCR cycle of 30 or less is considered to be, highly significant and potentially infectious. So obviously the patient who has a PCR cycle of 25 to detect the virus, certainly that's very concerning, but PCR cycles that are in the 30s or in the high 30s are certainly questioned, whether or not they could be infectious or not. So remember that this is a virus that can be found on all surfaces in patient care areas and on all surfaces that healthcare workers use, and this has profound implications for why hospitals have become epicenters of these outbreaks, because not only do patients transmit it to healthcare workers, but then healthcare workers transmit it to each other in these highly contaminated areas. Now, the median incubation period is approximately 5 days, and there's a spectrum of that. So obviously, that's the median, but most people will develop illness within about 12 days, and the longest that you would go from infection to developing symptoms of illness would be about 2 weeks. Now, the initial presentation varies as to whether or not you have a mild, moderate, severe, or critical version of the illness, and most of the initial experience has been on hospitalized patients. The spectrum of patients with mild infections may be very different, for example. Studies coming out of the US from Washington State and New York suggest that GI symptoms are actually more common than was described in the initial Chinese experience, and anecdotal reports of loss of smell and taste may predict a more benign course. Clearly, fever and cough are the most common manifestations that we'll see, and things like rhinorrhea are actually much less common in hospitalized patients, but there's no highly specific symptom that tells you whether or not a patient has COVID-19 or not. Now, this is an important slide that lists the possibility of 3 stages of the illness. An early stage, which is considered the viral response phase, and it's predominantly the early part of the infection. Stage 2, where there's a pulmonary phase where the viral response is diminished, your viral replication is diminished, but the host inflammatory response is beginning to increase. And finally, a potential hyperinflammatory phase where the host inflammatory response dominates, but viral replication is no longer occurring. Not all patients will have all phases of the illness, but in the sickest of the sick patients, it is believed that many will develop an overly exaggerated host inflammatory response, ultimately ending up in ARDS, SIRS, or a shock-like picture, potentially a cytokine release syndrome with cardiac failure and death. These patients are categorized by having elevated inflammatory markers such as CRP, LDH, IL-6, D-dimers, and ferritins, and they can also have evidence for cardiac injury with troponin and elevated NT-proBNP. In the early viral response phase, the constitutional symptoms seem to predominate, and signs, clinical signs of a viral infection like lymphopenia or elevated D-dimer and mild elevations in LDH predominate. In the pulmonary phase, this is where shortness of breath and hypoxemia predominate, and abnormal chest imaging as well as other findings occur. It's important to try and consider which phase of the illness a particular patient is in, because in the earliest phases, it's possible, not proven, but possible that antiviral therapy may have the greatest benefit, whereas in some of the later phases characterized by hyperinflammation, it raises the question as to whether targeted anti-inflammatory therapies could be potentially helpful. In patients who are in the early stage of illness, it's also important to point out that whenever possible, reducing the level of anti-inflammatory or immunosuppressive drugs that patients are on early on may be beneficial. So this is a complex equation with multiple phases of illness, and it can look different depending upon which phase the patient is in. Now, we mentioned that COVID-19 is a viral pneumonia and a severe viral pneumonia that can lead to ARDS. But I don't want you to think that that's all that it is. And there are many other manifestations. It is truly a multi-system, multi-organ disease. Abnormalities of liver enzyme have been demonstrated. There's an increasing recognition of acute kidney injury, especially in the US experience. Again, we mentioned that there are GI symptoms that occur. There are now starting to be encephalitis and other CNS manifestations that are occurring. And I want to remind people about the emerging role of hypercoagulability, including microvascular and macrovascular thrombosis, as well as the involvement of the heart and the blood vessels that we'll consider shortly. Now, typical data on a patient presenting to the hospital, so these are moderate or severely ill patients, include abnormal CT findings. And again, this really is coming out of the Chinese experience where they relied on CT to a greater degree, chest CT to a greater degree than they did even initially with viral PCR testing. The other findings are relatively nonspecific. Lymphopenia is typically present, and you can see listed here a variety of other laboratory abnormalities indicating inflammation and multi-system organ involvement. Chest radiographs do progress throughout the course of this illness. You can see a varying degree of dates and times of different patients after the onset of their symptoms. And you can see this very characteristic pattern in almost all cases of ground glass peripheral opacities that can be quite severe and quite substantial, resulting in hypoxemia, ARDS, and in some cases the need for mechanical ventilation. Now, this is coming out of the World Health Organization and the China Joint Mission on COVID-19, and this is really a schematic that summarizes how the patient can present at the time of their initial illness and lab diagnosis, as well as what the possible outcomes can be. The vast majority of patients will recover, although some will require hospitalization, ICU care, and a percentage of patients will die. It's challenging to calculate the actual case fatality rate or the death rate, given that it depends upon how many patients are tested, how many patients recover, and how many patients whose deaths are attributable to COVID-19. It's also important to point out that the actions of the health system and whether or not the health system has capacity to care for patients also has an impact on the case fatality rate as well. As you can see here, the vast majority of mild and moderate patients, and even those with severe illness, will recover. However, patients with any initial phase of illness can go on to develop severe illness, require an ICU, or even die. And you can also see that a greater percentage of those with severe or critical illness will go on to require ICU care and obviously die. This is a time course for patients who are critically ill, who survived and who did not survive. And again, you can see it's relatively similar in the sense that it's approximately 20 days from the onset of their symptoms to about 3 weeks to the point where they can be discharged. And it's approximately 20 days in those who did not survive to the point where they die. But patients are sick for about 3 weeks with this illness, and they can go from developing symptoms to death in about that time frame on average. Now, why do people decompensate? Well, the sources of decompensation are mainly anecdotal, but certainly people can decompensate from respiratory failure, which can be rapidly progressive from hospital admission and can often occur 7 or 10 days out from symptom onset. Patients do develop shock, and the onset of shock has been described when respiratory failure seems to be resolving. And this has been described as a cold clamped form of shock, a vasoconstricted form of shock, with cardiac dysfunction being demonstrated by point-of-care ultrasound testing. Patients have been described to have VT and VF and PEA arrests as the final mode of death. Now, it is important to point out, and we'll have a whole segment on this, that COVID-19 deeply affects patients with cardiovascular risk factors and cardiovascular disease. This was true in the SARS and MERS epidemic, and it's also true with COVID-19. Cardiovascular comorbidities like hypertension and diabetes and cardiovascular disease are associated with an increased risk of getting COVID, needing hospitalization for COVID, needing ICU care for COVID, and with reduced survival. And these include things as simple as hypertension and diabetes. And the possible mechanisms are purely speculative, but include the prevalence of cardiovascular disease with increasing age, because there has been an age association with morbidity and mortality in this disease, but also the immune impairments or imbalances that occur with age, and elevated ACE2 expression that is seen in RAS-activated states. And we mentioned this earlier, but ACE2 is required for binding of the SARS-CoV-2 for COVID infection. And ACE2's primary biologic function is to cleave angiotensin II. And angiotensin II is the most vasoconstrictive substance known. And it is known that ACE2 is downregulated by the virus. So this can theoretically lead to unopposed angiotensin II, i.e. unopposed vasoconstriction. And it is interesting to see that some critically ill patients with severe COVID infection have very severe pneumonia and ARDS, but have extreme hypertension. Preclinical studies have shown that RAS inhibition might upregulate ACE2, therefore increasing the risk of getting an infection or increasing the severity of infection, leading to concerns about using RAS inhibitors like ACE inhibitors or angiotensin receptor blockers in COVID-19. However, this has been looked at, and there is absolutely no data to suggest that ACE inhibitors or angiotensin receptor blockers have a deleterious role, despite what we might have seen theoretically or in preclinical trials. And all of the societies, including the American Heart Association, American College of Cardiology, the European Society of Cardiology, have all suggested continuing RAS inhibitors like ACE inhibitors and ARBs when clinically indicated. And in fact, there are clinical trials ongoing now looking at angiotensin receptor blockers in mitigating pulmonary injury in patients with severe COVID-2 infections. Now, this is a slide that just shows that cardiovascular disease and cardiovascular risk factors is a risk factor for severe COVID-19 disease. So older patients, chronic kidney disease, diabetics, hypertension, any cardiovascular disease, our heart transplant patients, and obesity are all epidemiologic risk factors for the most severe versions of COVID-19. Now, I'm not going to talk a lot about myocardial injury because this is going to be covered in detail by Penn Cardiology Fellow Michael Levin in the next episode of the Heartbites series, but I do want to underline the fact that myocardial injury, as described with elevated troponins, has been associated with increased risk of not surviving. And patients without cardiovascular disease can have elevated levels of troponin, and troponin is much more prevalent in high levels in people that don't survive versus those who do, and is an independent risk factor for in-hospital mortality. Now, there are multiple patterns of possible cardiac injury, which include a rising troponin along with other biomarkers indicating the possibility of a cytokine storm or cytokine release syndrome, a form of secondary hemophagocytic lymphohistiocytosis. And there are other patients that are presented with the possibility of clinical myocarditis. So I encourage you to listen to Dr. Levin's episode about COVID and the heart. I believe he'll review all of these manifestations, but remember that when cardiac injury is present in a COVID-19 patient, there is a differential diagnosis with multiple possible pathways of cardiac injury, including systemic inflammation, so-called cytokine storm, hypoxemia and oxygen supply-demand mismatch in critically ill patients, the possibility of direct ACE2-mediated damage into the myocardium or into the vasculature, and finally, cardiac microvascular damage from disseminated intravascular coagulation and microvascular thrombosis. The bottom line is that all of these pathways can lead to acute cardiac injury, which can pile on and produce morbidity and mortality in COVID-19. Now, there are no proven therapies for COVID-19, and I want to underline that we need randomized controlled trials to help us understand how best to treat our patients. There's poor quality data with no clear clinical benefit and increased cardiovascular risk when considering chloroquine, hydroxychloroquine, and azithromycin, and there's no routine role in the treatment of patients with COVID-19 or prophylaxis of exposure. The only use of these agents should be guided by participation in a randomized controlled clinical trial. A number of other antivirals have been proposed and have been used on a compassionate use basis in a variety of situations, and suffice to say that many of them have been disappointing in clinical trials, with remdesivir being currently evaluated and being available in clinical trial and compassionate use in pregnant patients. There's a potential role of convalescent plasma, But again, this needs to be tested, as well as the role of prophylactic or full dose systemic anticoagulations to deal with the thrombotic aspects of this disease. And there's the potential for steroids in highly select patients, although this is typically not used in ARDS per se. And there's the potential for anti-inflammatory therapies to treat cytokine release syndrome, including IL-6 or IL-1. All of these treatments need clinical trials, and none should be used routinely in the care of patients with COVID-19. I'm going to end my talk by pointing you towards a resource which was developed at Penn by the Education Office by many of our cardiovascular fellows. And this is a free, accessible resource for all of you. You can click on the link that's provided here in the slides. And this will take you through all of the cardiovascular manifestations of COVID-19, including guidance from all of the major cardiovascular societies, all of the clinical references, and many of the things that we may have alluded to today, and you'll hear more about in Dr. Levin's talk, all of the currently ongoing clinical trials, as well as many, many other resources from societies, limited resource allocations, and even social media. So I encourage you to access this. It's updated at least once and typically twice daily. And this is a great resource for cardiologists and cardiovascular healthcare workers that are interested in learning more about COVID-19. Finally, the mechanism for getting questions about this particular talk is to email Mark Hartnett, who's the executive director at CVI. And absolutely, I would like you to email him any questions that you might have, and he can forward them to me. I want to thank you for participating, and for more information about other CVI Heartbite topics and upcoming programs, please visit the website cviphiladelphia.org. And again, you can follow CVI Philadelphia Twitter at their Twitter handle here, and don't forget to use the CVI Heartbites hashtag. This is Dr. Frank Silvestry thanking you for your participation and for your attention, and I look forward to collaborating with you on taking care of these challenging patients and on future CVI educational opportunities. I'm going to sign off and get back to work here at the Hospital of the University of Pennsylvania. Thank you.